안녕하십니까? 이좋은 치과의 손영희입니다.
Greetings, I'm Dr. Sonyoung of eGood Dental Clinic. Today I'm going to talk about the Crestal approach using Osteotome. I'm going to talk about sinus floor elevation in this regard. This is Osteotome technique. Osteotome sinus floor elevation is going to be discussed. It's a type of Crestal approach in the area where implant is placed. Through melting, the sinus is fractured and it is lifted. OSFE, you can fracture the sinus floor, or as shown, you can just do elevation by 1 to 2 millimeters. You can do sinus floor elevation in this way. In the beginning, we talked about sinus floor elevation without fracture. OSFE does not engage sinus membrane directly. Through increase in osteotome diameter, drill hole is expanded, and in final stage, a final diameter osteotome is used to lift the sinus. At times, it doesn't work. Sinus floor's cortical bone thickness or other factors come into the play. This is how implant is placed. The OSFE means that you do not do bone graft. The amount of elevation you can get with OSFE is about 1 to 2 millimeters. That is the goal. Gradually, concave end osteotome is used with melting, and considering the fact that the upper bone quality is soft, elevation is done, and implant is placed. This is the OSFE technique. OSFE technique does not require graft material, and there's no perforation of sinus membrane because although elevation is done, it does not engage the sinus membrane. Also, you can improve bone quality, and you can get better primary stability. It's more favorable. Also, you can reduce patient discomfort by not doing sinus surgery. Then you can reduce the surgical trauma. However, it's technique sensitive. It's difficult to do. Also, this procedure requires very slow progress, so you need to do it very gradually. It takes a lot of time. It is said to improve bone quality. This is entirely limited to primary stability, and according to literature, in terms of overall implant stability, it does not show favorable results. This is a study from 2005 compared with implant placed with drilling and implant placed with bone compaction with osteotome. BIC were compared. Bone to implant contact ratio were compared. BIC at 7 days and 28 days were compared. As for the drill group, the BIC increased from 43.78 to 63.47. As for osteotome, the numbers grew from 35.88 to 44.81. The number is actually smaller. So in the very early stage, it may be of help in primary stability, but in terms of bone regeneration or osseointegration, it's not of great help. As a result, I believe that the bone compaction technique in terms of addressing the soft bone in the upper has little efficacy. The second way is BAOSFE, where sinus floor is fractured. This is bone-added osteotome sinus floor elevation. In most cases, sinus floor elevation involves a BAOSFE. You would lift the sinus floor using osteotome and do sinus graft. To do this, membrane detachment and sinus floor opening are necessary. After sinus graft, the implant is placed. This is a most frequently used method. Even to this day, I believe that BAOSFE technique is more frequently used method, even more so than lateral approach in doing sinus floor elevation. Basically, osteotome or other kit is necessary. The basis is 5 mm. There needs to be at least 5 mm of residual bone height. You push bone graft material first, and then you fracture sinus floor so that the bone graft material can go on top. This is PAOSFE technique. These days, we rarely put the bone graft material first and then do fracture. After introduction of casket, this method is rarely used. Sinus floor is fractured and bone graft material is pushed in. Because of the pressure of the bone, sinus membrane is detached. This is BAOSFE technique. What is important in doing BAOSFE technique using osteotome? As you push bone graft material in, the osteotome should not be beyond sinus floor. If the residual bone height is 5 mm, you need to make sure that the osteotome does not go beyond the 5 mm point, or else it can fracture through sinus floor and membrane can be perforated. Therefore, we need to pay attention. And implant is placed. This is the BAOSFE method. Simply put, BAOSFE only uses osteotome without the use of casket. This is not to say that you should do this. When we use casket, at times the sinus floor can be opened incompletely. At the time, you can detach the membrane and use osteotome to complete the incomplete sinus floor fracture. At this time, osteotome may be necessary. Up until now, this method was used. This is not so much frequently used these days, and as we continue to find improvements, casket became introduced. Let me share with you BAOSFE case number 26. Implant has been placed here. BAOSFE technique was used, and this is quite some time ago. There was no casket and there was only osteotome. Bone graft was done and implant was placed. And bone has been formed like this. In some sense, if we can get this kind of result, then it's very good. The biggest problem with BAOSFE technique is that we do not know in which direction membrane is going to be detached. We have no clue. Also, we have no control whatsoever as to where the bone graft is going to be done. This is the biggest problem. Let's look at another case. In number 16, there was a problem and extraction was done. Implant was placed. A BAOSFE technique was used, and as you can see that bone graft is here. Graft has been done like this. Is this proper? I do not believe so. This is my case. As you can see, it's more clear here. It's up to here. The bone graft material is only up to here. Post 4 months and 5 months, prosthesis was delivered. Even if bone graft has gone up, because of gravity, it tends to come down, unless there is membrane tear. As the bone graft material come down, you cannot tell where it has been grafted. Post 5 months, you can see that bone formation has been done like this. However, it's unclear as to bone fill occurred because of bone graft, and below the detached membrane, bone fill occurred naturally, in my opinion. The bone graft material are all gone. In which direction bone graft is going to be done and whether it's going to protect the implant, we have no conviction whatsoever. In this case, this is post-op 10 months. If you look at panoramic image, you can see slight bone formation here. This is the anticipated result. If you are an excellent surgeon, then you can get better results, but in general, this is the kind of result you can anticipate. Let's look at this patient. BAOSFE was done. Osteotome was used to place the implant. Bone graft has been done like this. This is a nicely done case. The reason being, if you look over here, let's go back a little bit. The patient's sinus shape is like this. It has concave area. In this area, if bone graft is done, we'll get good results, and membrane detachment, if it's done here, it's going to go up only up to this point. So bone graft material is going to be concentrated here, and that is why we got good results. So this is post-op 12 months. This is panoramic image. You can see bone formation is nicely done, and in the sinus floor, cortical lining has been repositioned. Pre-op, post-op. The sinus floor has been repositioned. If we can get this kind of result all the time, it's great, but that's not necessarily so. BAOSFE can lead to good results. However, at times you can get a not so favorable result. You can see that in the case of this patient, upper left is edentulous and BAOSFE technique was used. Bone graft is done like this. Ideal membrane detachment and bone graft should look like this. However, detachment was not done up to here. None whatsoever. Membrane has been detached like this. If you look over here, it's been done like this. What's going to happen? Post-op 12 months, if you look at panoramic image, something looks off. There's bone formation here and there. But the bone graft that I've performed is over here. It looks like a lollipop. We come across this kind of case more frequent than anticipated. The membrane detachment was not done perfectly, so graft material was not positioned as planned. We don't know where the bone graft material is going to be positioned. Another big problem is we don't know how the bone remodeling is going to occur. That is the biggest problem. That is why different tools for Crestal approach have been developed. Osteotome technique's limitation, as shown, it's very technically sensitive. If you're good, then you can do a good job, but once you get mixed up, then it can be very difficult. When we measure the height of residual bone wrong, then things can get really difficult. For instance, let's assume that there's about 7 mm of residual height. Here, it's 6 mm. How do we determine where to place? We look at the antagonist in determining that, and we also look at how much of buccal bone there's going to be left. If this is atrophic ridge, in most cases, the lower would protrude outside because on this side there's resorption. In that case, how will implant be placed? Will it be done like this? No. There's higher possibility of implant being placed wrong. The assumption was that there was 7 mm of bone left. However, in this case, try as we might, we will not be in contact with the sinus. A lot of people experience this. If the assumption is that there's 7 mm of residual bone height, then you leave 1 mm and drill about 6 mm. After that, we would use osteotome to penetrate the sinus floor. It will work this way. However, in this case, the sinus floor will not penetrate because there's too much bone left. These kind of errors occur very frequently. The osteotome fractures the sinus floor. That is the technique. If you measure the height of residual bone wrong, this is a blind technique, so there can be limitations. At times, the cortical bone may be too thick, and no matter how hard you try, you will not be able to penetrate the sinus floor. The osteotome technique has these limitations. It increases patient discomfort. Osteotome has this clear sound, which causes distress on the patient. Second, as mentioned with the case, we cannot anticipate how elevated the membrane will be, and we cannot control that, so there's a lot of limitations. Once the graft material goes in the sinus, so we do not know how much regeneration will occur. What is most important in this respect is the contact between bone and graft material within the sinus. That is most important. If the membrane is detached inappropriately and insufficiently, then the contact will be reduced. Hence, it will be difficult to anticipate bone regeneration in an optimal manner. These problems can occur in this way. Let's look at the level of difficulty of osteotome technique. When you look at the sinus floor shape, it can be divided into slope, flat, peak, and deep depression. This is the general classification. If you look at the level of technique, deep depression type of sinus is most common, and it is easiest to regenerate the bone here. Followed by flat and slope. A slope is difficult. The peak, it's very difficult. So the criteria should be like this. When you look at sinus floor form, you need to come up with a plan following the form of the sinus. When you use osteotome in the case of peak sinus floor, then elevation will not occur at all. In the case of deep depression or flat sinus floor, the level of difficulty is quite easy. In the case of sloped form, there's very high possibility of incomplete fracture. These days, we do not use osteotome and use casket. Even if sinus floor opening is incomplete, hydraulic pressure is used to detach membrane, and then drilling is performed. These days, this type of sinus is not really difficult to treat. However, if you do malleting with osteotome, this kind of sinus can be extremely difficult to treat. In this case, membrane perforation can occur very easily. Mallet comes in like this, so there's very high possibility of membrane perforation. This kind of sinus, it's very difficult. It's very difficult to penetrate like this. Membrane detachment is done like this. Peak sinus. In my opinion, it's very important we do not place the implant here. This is something that we want to avoid. If you want to detach membrane here, in my case, I would rather do lateral approach. Peak sinus, green stick fracture should be avoided. It's very difficult to avoid membrane perforation. Membrane elevation is extremely difficult as well. In this case, in some sense, this can be considered contraindication for sinus floor elevation using osteotome. One of the problems with using osteotome is BPPV. This stands for benign paroxysmal positional vertigo. If you do excessive malleting within semilunar canal, The otolith can be deviated so the patient can experience extreme nausea or dizziness. This refers to BPPV. This can occur due to melting. If you look at the literature, the possibility of BPPV is about 1.25%. In order to prevent it, you need to do melting in a very gentle and gradual manner. If you do it excessively, these complications can occur. In the case of BPPV, you need to have the patient rest. If the patient has to work, this can be a problem. Anti-vertigo medicine can be prescribed. Antihistamine or scopolamine kind of drugs can be prescribed. Epley maneuver can also be done. You have the patient move. You have the patient rotate their head gradually to reposition the otolith. If you know about Epley maneuver, it's great, but once BPPV occur, you need to refer the patient to ENT. I think that'll be of more help. Today I've talked about doing sinus floor elevation using osteotome. There are other considerations and things to discuss. However, to address them all, it will become too long. If you're interested in the topic, please come to the offline master course to get a better and deeper understanding. Thank you for watching.